Good morning. My name is Jennifer Colucciello, and I'm going to talk today about equipment management and medical emergencies. To get us started, let's go ahead and do the ID here. I hope I got that close enough for you. And the attestation. So all Aspen University students are required to abide by Aspen University's academic integrity policy as outlined in the university catalog. The academic integrity policy is built upon the concepts of honesty, truth, fairness, respect, and responsibility. By taking this assessment, I agree to abide by both the academic integrity policy and the rules outlined in this assessment. With this recording, I am attesting that I have personally completed the proctored assessment and that the information I submit is true and accurate to the best of my knowledge. So let's go ahead and jump in. So as a certified medical office manager, this is actually quite part and parcel to a lot of what I do every day in my day job. So I found this very, very interesting and very, to be honest, what I do all the time. So interestingly, I tell my physicians all the time that in order for them to practice medicine, I must actually be able to master the business of medicine. Without mastering those components, and this includes real estate, support functions, employees, payroll, emergency response, patient interactions, customer management, and so many other things. Without managing and being successful at the business of medicine, they will not be able to practice medicine. And that is evidenced by a lot of the things we discuss here. When it comes to office equipment management, there are so many different categories. There are safety equipment, including all of the PPE, the protective items, response items. The clinical equipment is typically the first one that comes to mind for everybody, including everything from vital sign techniques, diagnostic testing, imaging, crash carts, equipment in an exam room, and so much more. But there's also clerical equipment, which, if is not actually accurate and functioning well, will also have detrimental impact upon the practice. This clerical equipment includes all of the typical desks, papers, pens, and computers and so forth, but also includes the patient health record. The EHR is something that, when it crashes, is a major, major concern. Thankfully, it does not happen often. But in any clinical practice, when the EHR goes down or does not function properly, even at one point, it creates a cascade effect, since so many things are pulled from a different spot within the system. In the office equipment management, there are multiple ways to go about this. Maintenance specifically is a huge one and really needs to be looked at, not from a response perspective, but from a prevention perspective. So it's really important to actually read the manufacturer guidelines, the inserts that come with the pieces of equipment. It tells you everything you need to know. Storage, what needs to be checked, how to check it, calibration, so many different considerations on best how to utilize and protect the equipment. That information, along with the calibration specifications, needs to be done on a routine basis. You have to have those function checks. These are things that actually come up in lawsuits where they ask, how did you verify that that equipment was still functioning, that it was appropriate, that you took care of it, and so forth. So having logging for that, whether digital or hard copy, but a way to make sure that you are measuring things, the function, the calibration, and so forth properly, and able to track and trend that is exceptionally important. There also needs to be routine upkeep where you check power cords, make sure they're not fraying. Look at your microscope, make sure everything's aligned properly and that the magnification is correct. There's actually certain biometric upkeep that needs to be done for a lot of the equipment, and that's something that also needs to be logged. When it comes to looking at our real estate or our large purchases, we have to consider leasing versus purchasing outright. There are some very, very key functions here and considerations, especially related to the business side, just simply from the P&L side. So there's a couple different pros and cons for both, and what your business structure is, what access to funds you have is going to be key, your credit availability, and so forth. But there are ways to set yourself up for success. When it comes to the leasing, some of the benefits here include, if I've leased it, I'm not required to do all of the maintenance and repair costs. That can be built into the lease, that the owner is still mostly financially responsible. And because I'm not the owner, I also have decreased risk and liability to go with this. Some of the negatives of this is because it's not my equipment or my building, I have less autonomy with it, I have less oversight. I also am losing potential revenue. If I'm sharing that cost or having to pay somebody else, any money that I'm making, I'm also sending out the door. So that's some concerns with leasing. Purchasing, on the other hand, has some additional ones. And this is where we come into increased autonomy. Obviously, if I own the item, I can do everything I need to do with it. I can also make money on that. Real estate itself is a very, very big one, or ownership of large pieces of equipment. So many private practices actually create a separate LLC, not just the medical component, but an ownership landlord type. This is the part of the company that actually owns the real estate, large equipment, and then the practice rents and leases the real estate or the building or the site or that large equipment from the owners of the landlord component. So it creates another way to actually make some money. Some of the negatives here, of course, if I own everything outright, I have increased cost in licensing and responsibility and liability regarding to everything that goes wrong with those pieces of equipment. So let's switch gears to one specific component within some of these functions, because there are multiple levels along the entire process of the business side and the support functions that needs to be addressed. One of those is transcription machines. So thankfully, technology is advanced. There are lots of numerous ways to do this that are more efficient than they used to be. AI has created an abundance of efficient and time-saving methodology for this. But essentially with transcriptions, the doctor is just speaking out what they're saying, either into a dictaphone that is then a tape put into something, or a call-in function. Typically surgical centers use this. You just call in after the case, explain everything, and then it's automatically transcribed and then sent back. A lot of the newer EHRs have built-in transcription. You can hit voice to text and it will actually transcribe everything you say, do a few little adjustments, and then you're good. Azure is one of those that works spectacularly well. That's the one I use in my practice. The whole point of this is to maximize the physician's time, because they're not taking the time to write or do data entry on their document. They can free text all of those other things by simply saying them out loud, and the system can do that. It gives us accurate documentation, supports our medical necessity for billing purposes, allows for continuity of care, and we're able to actually set that the note itself, once it's locked and that is verified, that the note itself can automatically send via a digital fax directly to the care team members that are selected. This cuts down numerous points of time and makes the whole thing a little faster. Another area we look at is inventory control management. There is a lot of equipment coming in, going out. Depending on what specialty you're working in, this can have more or less, but most specialties have something that's coming in and coming out. Almost every specialty now has injections of medications for specific specialty-related diseases. We have to keep on top of that inventory, or else things expire. We don't get paid appropriately. We have to make sure that we're actually collecting the 106% that we're allowed by CMS on those medications. 6% is a very small margin, and so it can take not very much to actually be not reimbursed and recouping those costs. So inventory management systems are amazing. The wonderful thing about these, and there's two that come to mind. One is PODIS, P-O-D-I-S, and another one is McKesson's. They are spectacular, and they interface directly with the inventory management, our vendor, and our EHR. This is wonderful because it allows for easy report and tracking, both from the P&L perspective, but because it interfaces with the AR and the patient record, it actually allows us to see reporting from the inventory management as well as the AR side. It gives us correlation to let us know we're getting reimbursed appropriately for the inventory we're using. It also is able to tie into our vendor, which allows us to set thresholds for, at this threshold, you need to place a new order. And then we can set that order threshold, that if I go down to 10 of, say, Avastin, I'm going to order another 40. There are ways to do all of that. Another benefit of the inventory control management interfacing with the EHR is that we're actually able to just select the drug that we're using, and we can pull it right from that inventory listing, and it will import in 2 to 3 clicks the name, the dosage, the lot number, the expiration date, all of those items, delivery system, NDC numbers, and so forth. All of these things give us better control of our inventory and our finance that's related, as well as saves time from an operational perspective. When we look at policy and procedure manuals, these are just invaluable and have to be there. The whole point of these is to set clear, concise expectations and processes. Many people think that there's really only one, but that is not the case. There actually needs to be several different components. Could be into one large one, but that ends up being unwieldy. So there needs to be a component of a human resources manual, typically the employee handbook. There needs to also be an OSHA one, a compliance manual, typically includes HIPAA, and then clinical processes, clerical processes, research, if your company is doing healthcare research, and then operations. These are all things that need to be covered and addressed and clearly delineated to keep everybody on the same page. With these, we have to review them and make sure that everybody's aware of them, where to find them, how to use them, how to read them, and so forth. These documents are going to set the standard to provide clarity, consistency, and reduce confusion. They have to be in place with the company in order to allow us to scale up or out, whether we grow or we outsource as an MSO. But this is excellent, especially from the HR function. It's really hard to hold somebody to a metric or to a process if you don't have it delineated. This makes everything so much easier and more objective. Now, the medical assistant role in emergencies is multifactorial. There's a couple things here. The medical assistant in this role is so key, typically because they're the first one to recognize the issue. The physician is typically in a specific patient room and focused on that patient at the time. Whereas an MA, even though working up a patient over here doing a test and so forth, the MA is managing the flow of all of the patients during the session. And so they typically are the first ones to recognize an emergency, which allows them to hopefully be able to identify the correct issue and then get that response started appropriately. That response is going to include several different things, and the MA needs to be prepared to do so. This includes initiating stabilization, activating emergency response, making sure that the patient is safe, assisting the physician in any response that is needed, any treatment, and so forth. They need to be able to perform first aid measures on their own, and they need to, after the event is completed, make sure that they can document everything appropriately. When they identify that there's a medical emergency, there's a couple screening things that need to happen. They need to start with some basic questions. First, we need to make sure that the patient is safe, that I'm safe, that we're all safe. And then we need to start with patient-specific questions, and they include what's listed here. Can you hear me? Are you okay? Are you having chest pain, difficulty breathing? Do you remember what happened? Does your head, neck, or back hurt? Some of these items will then lead the MA in the direction they need to go, and then they can be sure to keep them safe, protected, and assess from there. If the patient is unresponsive, then they're going to check a carotid pulse. If the patient is responsive, we're going to go to a radial. But the MA needs to understand some of these components, and then they need to be able to respond appropriately. If it's problems breathing, what do they do for that? Give them oxygen, and how do they do so? If they're having chest pain, do we talk about nitroglycerin and aspirin? If they fell and their head, neck, or back hurt, let's keep them still. Stabilize that neutral inline stabilization of the spine until EMS can get here. So the MA has a significant role in that. More specifically, if the patient goes into cardiac arrest, they must know how to use an AED, where to find it, and how to use it. The wonderful thing about an AED is all you need to do is turn it on. If you can turn it on, it will, slightly obnoxiously, tell you what to do the entire time. But it's not just the AED. The medical assistant needs to understand that if you're pulling out an AED, you also need to be activating 911 and you need to be starting compressions. At that point, turn the AED on. It will tell you what to do. Attach the pads, don't touch it so we can analyze, and then it will advise you shock or not, and if you need to continue compressions. But at that point, you need to know where it is and how to open it, that you need to actually turn it on and then go from there. Another big emergency that comes up is bleeding, lacerations, and so forth. I can tell you I've had many patients actually fall in the parking lot and then walk into the office. So there's some specific concerns on how to address that. For minor wounds, you're simply going to make sure you're gloved, and then the MA needs to apply direct pressure and elevation if possible. Once the bleeding has been controlled, then they're going to go ahead and bandage that wound. We want to disinfect, apply a triple antibiotic to prevent infection, make sure it's clean, and then we're going to bandage with a sterile dressing on top, gauze, and then wrap that with gold rolled gauze, cling. It's elastic, and it actually gives you the best way to do that. The tape will actually hurt her much better than if you're taping gauze down to skin. If there are moderate wounds here, then the physician may need to actually decide if we need to do steri strips, butterfly, wound glue, sutures, or any other type of wound closure device. If instead it is a severe bleed, we need to, of course, do gloves, direct pressure. We need to also then do 911, and we need to consider, if we have them available, hemostatic gauze, such as QuikClot, which actually the enzymes react with the proteins in the gauze, creating a clot, which is amazing. And we also need to consider a tourniquet to actually stop the flow of life-threatening bleeding. But if there's a severe, this is direct pressure, 911, and then if they have these available, then they should do so. Responding to an emergency is one thing, but we also need to look at how to mitigate them and prepare for them so that we have what we need. And the MA also has a lot of say in that process. So the MA should also look at helping to identify and update the hazard analysis. What are the risks that we could come into contact with here in our location? Once you've identified those risks, you need to develop, implement, and then maintain the equipment to respond to those and the processes around them. If you identify medical emergencies as a concern, then I need to build a first aid kit. I need to maintain it, make sure things are not expired, and I need to make sure everybody's trained. When it comes to the training, this is another role that the MA has that really can just be expounded upon just to make sure everybody's good. This includes doing those practicing, doing reviews, updates, even tabletop drills, talking through, if this happens, what are we going to do? How are we going to get people out of the building? If there's an active shooter, what are we going to do? They should also practice these. This is why places have fire drills and things like that. That way we practice what we're going to do. That way when we're panicking, we have some muscle memory that will help to get us through that. They should also look at considering bringing outside subject matter experts in. This is really, really an important one, especially when we're talking about active shooter concerns. For medical offices in an urban environment, they are at higher risk. We know that from the FBI statistics. And so one of the things they can do is actually reach out to their police department via the non-emergency numbers. But a lot of times these police departments will send an officer out to actually go through the office, look at what their risks is, help them mitigate those risks, and train them on how to respond in an active shooter situation. The MA has a lot of role in that because they can help guide that to make sure everybody is safer in the long run. These are just some of the components. There is a lot to consider in the business of healthcare from so many different angles. But again, if we can get these items right, if we can master the business of medicine, including all of these, we'll actually set up our practice for success and give our team and our physicians the ability to focus on patient care and deliver quality care to those patients, which is what we're looking for. And just a couple references here just to support that. Thank you.